So let me introduce Dr. Noe. Dr. Noe is an epileptologist and an associate professor of neurology at the Mayo Clinic. She's currently the director of neurology there and has been involved with our foundation for many years. She served as a chair of our board for 6 years of her 9-year tenure, and she hired me. Um, she is also the co-principal investigator of, oh no, I'm sorry. So Dr. Noe is going to be presenting on management of epilepsy in women. Go ahead, Dr. Noe. Thank you.
Thanks for having me. Good evening, everybody. I really enjoyed that last talk. I'm wishing I had been creative enough to put some of my dog pictures in here, but I'll hopefully, even without the dogs, this is helpful for you guys. So we'll spend the next 40 minutes or so talking about unique aspects of management of epilepsy in women. And I want to just start with some urban myths, so to speak, that I'm going to address in these slides. I would love to have the day come when I present a talk like this and the participants all say, I've never heard any of these things, but I don't think we're there yet. So these are untruths that even after all these years of trying to raise awareness and increasing good data about how to optimally manage epilepsy in women, I still hear women who have been told or who have heard from somewhere or believe that seizures have no relationship to your menstrual cycle and your hormones. And usually they know that it's true, but some doctor has said they're imagining it, and we'll talk about how this works. Women who have been told they should not have children because of their epilepsy or their seizure medicines, and for sure, I want to turn that myth for what it is, which is not true. And women who are told that if they do have a baby, they can't breastfeed. So let's kind of dig into this. In point of fact, you all know that managing seizures, regardless of your gender, your age, it can be challenging. There's some folks where things are easy, and then there's some times where things are really hard. So we think a lot about seizures and how to manage them with medication. But for women of all ages, there's an additional influence of their female hormones, so estrogen and progesterone, and how that may influence their seizure control. And then their seizures, by disrupting hormonal regulation pathways at the level of the brain, may also adversely influence things like their fertility, their menstrual cycle, where they are with their hormones. And the seizure drugs, although we prescribe them to control the epilepsy, the seizure medications can start impacting the hormones or some of the hormones you might be taking, whether it's for birth control or whether it's for menopause. So tonight, this is so complicated, we don't have time to go into everything, but I want you to know that these relationships exist, and we'll talk about some of the highlights. So let's start by digging into seizures and the menstrual cycle. If you talk to women, if you survey women with epilepsy, somewhere between a third and half of them will say that the likelihood that they will have a seizure on a given day of the month is very predictably linked to where they are with their menstrual cycle. So if you've observed this, it's not your imagination and you're in good company. The most common pattern that people note is that they're very likely to have seizures in what we call the perimenstrual period. So this is a couple days before, a couple days after the onset of menstrual bleeding. Many women, that's the most common pattern that women find they're very vulnerable there, and I'll tell you why. The second most common pattern is what we call pre-ovulatory, meaning right in the middle of your cycle when you're ovulating, that is another time where women may be more vulnerable to seizures than in the rest of the month. So why is this? We have very good data from animal models, from lots of studies to say that estrogen, which does act on the brain, there are estrogen receptors in the brain, that estrogen makes it much more likely that a seizure will occur. It's pro-seizure, what we call a proconvulsant. Progesterone has the opposite effect. Progesterone is actually protective against seizures. So if you go through a cycle, any time in that cycle where estrogen levels are high, you may be more prone to having a seizure. And when progesterone is low, you may also be more likely to have a seizure. High progesterone would protect you. So this This may be kind of back to high school biology, but I think it's helpful to illustrate. I don't think most of us think about where we are with estrogen and progesterone, but this takes you through an average cycle. And the levels, the red line is where you are with estrogen and the blue line is progesterone. So let's start in the middle of an average 28-day cycle. So right in the middle here, you'll see what's called ovulatory phase. That's where a woman would be ovulating. And you can see that at that point, estrogen in the red is very high and progesterone is quite low. So it makes sense that estrogen, that pro-seizure, when it's high and there's no progesterone to balance it, you can see why a woman around the time of ovulation might be much more vulnerable to having a breakthrough seizure. If you go to the end of the cycle, day 28 or heading into day 1, that's the time of menstrual bleeding. So as you head into day 28, look at what's happening. That progesterone is really dropping off. So that protective progesterone is falling down, whereas estrogen, the red line, is staying relatively high. So this is the reason right in those days before your period or heading into your period that you may find yourself more likely to have a breakthrough seizure. So we can observe the pattern. Sometimes the most helpful thing about it is, like you heard in the last talk, one of the worst things about epilepsy is how unpredictable it is. So for some women, I would much rather they be seizure free, but at least they say, I know what days of the month I may have something and I can take extra precautions. But what we really want is for you to be seizure free. So how can we harness the information about what's happening with your cycle to try to do something to get the seizures under better control? Far and away, regardless of your pattern, regardless of the association with your seizure, the best therapy is still our standard anti-epileptic drug therapy. It would be very unusual that we could do something without an anti-seizure drug to get around this problem. There are limited data about alternate treatments. So if you're already on a conventional seizure medication, maybe you're on more than one, you continue to have hormonal mediated breakthrough seizures, what else can we do? Some women follow a strategy of taking extra seizure medication leading into the time of vulnerability. So if they knew, for example, my cycle is exactly regular, I have my period every 30 days, maybe 5 days before my period when I'm probably going to have a seizure, I'll take an extra dose of medicine to boost my levels. So this may work. It does require that your menstrual cycle is like clockwork, and it does require some planning. So it's not a strategy that works for everybody, but some women find that this is an effective way to manage things. There's also a drug called acetazolamide or Diamox. This is an old-time drug. It's, so to speak, a water pill, but there is some evidence that this medication taking around the time of vulnerability may also help lower the likelihood of hormonally mediated seizures. So for some women, that's a strategy they can use. Finally, sometimes the answer is let's not treat the seizures, let's treat the hormones. So you have to know, to pick a good strategy, you have to know when your time of vulnerability is. So if the issue is ovulation, if that's your vulnerable period, then we need to suppress ovulation. And that you might be able to do with just a conventional birth control pill. You're not going to ovulate, you'll still have a period every month. Or you could use supplemental progesterone, for example, to boost the level of progesterone at a time of vulnerability. If the time that you're at risk is when you have menstruation, then taking a standard oral contraceptive pill where you have a period every month, it's not going to get you where you need to be. We need to skip menstruation. We need to keep progesterone high. And the answer there might be to try what we call an extended cycle oral contraceptive pill, where you take active pills, you don't have a period every month. You might have a period once or twice a year at a time you schedule. So all things that might work, often prescribed in conjunction with a primary care doctor or your gynecologist along with your neurologist, but there are options out there. What happens when periods stop, when menstrual periods stop? The influence continues. Before you have menopause, so menopause is defined as when you have not had a menstrual period for 1 year. But before women enter menopause, usually sometime in their mid to late 40s, they enter what we call perimenopause, where they start to have some of the symptoms we think about of menopause, like hot flashes or disrupted sleep. They may notice that their periods are becoming more irregular, both as far as how heavy the bleeding is or what their cycle is. And during perimenopause, we see a lot of fluctuations in estrogen and progesterone levels. So unfortunately, many women with hormonally sensitive seizures may notice that their seizures get worse during perimenopause. When you hit menopause, though, no more estrogen, no more progesterone coming from your own body, at least. And that may be the light at the end of the tunnel. And that many women, especially those that were very strongly hormonally influenced with their epilepsy, often finally get relief or dramatic improvement of seizures when menopause comes. So there is an ending to the story sometimes. Now, menopause is not always the most fun stage of life for women because of the symptoms that go along with it. And so many women may want to consider going on hormone replacement therapy. It's a very complicated decision because of all the good that goes with it and the bad that goes with it, like, for example, impacting risk of breast cancer. So it's a complicated decision as to whether to use hormone replacement therapy and when to use it. But in regards to epilepsy, to know that if you have been hormone sensitive through your reproductive years, that unfortunately for many of those women, taking a synthetic hormone replacement therapy may actually result in increased seizure frequency, and it may mean that they can't successfully take hormone replacement therapy. So not to say you can't try it, but just to be aware, and like all things in life, you just have to monitor and see what happens with your seizure control. All right, so moving on from periods, what do you need to know about epilepsy if you want to get pregnant? What's the association there? Before I get into this, I really want to start with probably the most important thing I'll say to you over the next half an hour, which is that the overwhelming majority of women with epilepsy will have a successful pregnancy. They will have a healthy baby. So we're going to talk about how things can go wrong, but I want you to pay attention to the numbers I'm quoting very carefully and not let anything that I'm saying scare you unnecessarily. The other thing is I recognize that women with epilepsy, whether they're teenagers, whether they're in their 20s, 30s, 40s, concerns around pregnancy often are a significant source of anxiety. And just to keep it in context, yes, there are some unique concerns for you potentially, but remember that almost everybody worries about pregnancy and is their baby going to be healthy? So to some extent, it's just part of the normal human condition. So I want to empower you to know what the risks are and what the risks are not. So let's start with the basics. We're going to start with what can go wrong. So exposure to some medications that we use to treat seizures in the first trimester of pregnancy may increase the risk that your baby will have a major birth defect. And in this case, I'm talking about birth defects that have implications for the baby's health. They might be fixable, they might be surgically correctable, but this is things like cleft lip or cleft palate, problems with the way the heart forms, problems with the way the kidneys form or the genitals, or problems with the way the spinal cord grows. So many of them could be fixable. Cleft lip is fixable, but again, it's still something that you would want to know about and something that could impact what happens with your baby when they're born. The other thing I want to say before we get any farther on this is when we talk about what the risk is, know that 99+% of these types of birth defects can be detected on ultrasound early in pregnancy. So I'm going to tell you the likelihood it's going to happen, but I also want you to know that it's not that you would give birth to a baby and all of a sudden you would have no idea. You would have time to be aware, time to plan, and potentially some time to make decisions about what happens to that pregnancy. Okay, so we're going to go into a lot of data about birth defects. Some medications have also been associated with lower than expected IQ or with autism, and I'm going to give you the data on that. And the most important thing I can say is it's not all drugs, it's drug and dose specific. So I'm going to tell you which ones are bad, so to speak, and which ones are safer. All right. No woman who has a baby gets a promise that everything's going to work out great. So this is important to understand the numbers. So in the United States, all women, regardless of their health history, regardless of what kind of prenatal care they have or don't have, if you look at the outcomes of their pregnancies, about 2 to 3%, meaning 2 or 3 babies in 100 will be born with a birth defect. So that's all comers. If you look at women with epilepsy who are not taking a seizure medication, their risk is exactly the same. So why is that important? Now, let me say there's exceptions. There are people who have epilepsy as part of a larger hereditary or genetic syndrome, but the average run-of-the-mill epilepsy, just having a seizure disorder, doesn't mean something's going to go wrong with your baby. The risk is related to the drug. If you look at women with epilepsy who are on seizure medications, and in this case, we're talking about all comers, all drugs, all doses, all combinations, the risk that those women will have a baby with a birth defect is about 4 to 6%. So it is significantly increased, but remember that still means 95, 96% of women with epilepsy on medication have a perfectly healthy baby. The other thing that women are often told is, yes, the medication is dangerous or might be dangerous, but seizures are more damaging to the pregnancy. There's no evidence to support that statement. So we want you to be seizure-free during pregnancy for all the reasons I always want you to be seizure-free. You're working, you're driving, I want you to be safe. But if you were to have seizures during pregnancy, does it cause the baby to have a birth defect? No, it does not. All right, let's talk about specific medications because that's the real question. In other words, it's not do I have to be on any medication or no medication, it's do I have to be on this medication that my doctor is prescribing me. So we have actually quite a bit of data for a lot of our seizure medications, and these come from large international pregnancy registries. So these are women just like you and me who are on a seizure medication, who early in their pregnancy agree that they will share their story, they will share their outcome with a scientific group. And when their baby is born, they say what happened. They say what medication they were on, and they say what dose they were on. And so from these around the world, we have been able to get very good observations about the risks associated with these medications, as well as risks of seizures and other things that might be going on. So from thousands and thousands of these observations around the world, what stands out? There are some drugs that are high risk and we should avoid when possible. And there's other drugs that appear to be very low risk. In fact, they may actually be no risk during pregnancy. Far and away, the riskiest drug as far as birth defects is concerned is valproate, Depakote. Doesn't matter why you're taking it. The risk is probably higher. The higher the milligrams, the higher the dose, but even low doses are probably carrying some risk. And if you look at women who took valproate alone, meaning that was their only drug, the risk that their baby will have a birth defect in these registries is about 10%. So that's quite a bit higher than 2%, which is the general population risk. There's also increased risk for topiramate, Topamax. The risk is about 3 to 4%, but that's still higher than that kind of baseline 2 to 3%. So that's another one that we like to avoid when we can. And then the last drug so far that's really standing out is phenobarbital, a very old drug, but one that we still use. And the risk of birth defects there is about 6%, meaning 6 babies in 100. Now, let me say we have fewer observations. We don't use phenobarbital as much anymore as we once did. It's been around about 100 years. But nevertheless, still some concern. That's another drug we would like you not to be on if we can find something else. At the other end of the spectrum, we have thousands of observations of women who took levetiracetam and lamotrigine during pregnancy. And so far, there is no increased signal to suggest that they have any greater likelihood of having a baby with a birth defect than anybody who was on no medication. So we have some safer choices that we can try to move to if they are appropriate for mom's seizure disorder. What about drugs taken in combination? We all know there's some people who can be controlled with one seizure medicine, but some people may need more than that. They may need 2 drugs or 3 drugs. And early on, even 5, 10 years ago, we spoke about the idea that being on multiple drugs was inherently more risky as far as birth defects than being on a single drug. We get smarter, the longer we go, the more observations, the more pregnancy outcomes, the smarter we get. And what we know now is that it's okay to be on more than one drug unless one of those drugs is once again valproic acid, Depakote, or topiramate, Topamax. Otherwise, if you're on lamotrigine, levetiracetam, Tegretol, that's what CBZ is standing for, those drugs taken together, it's okay. It's really only, once again, when you add valproate or topiramate to the mix that the risk seems to go up. So 2 drugs to be particularly cautious about. How do we use this data? I mean, again, the role of this is to empower women to have healthy pregnancies while still having great control of their seizures. And this, I think, is really super encouraging publication that came out earlier this year from the European Registry of Anti-Epileptic Drugs in Pregnancy, that's EURAP, 21,000 women with epilepsy for which we have pregnancy outcomes, whether they took one drug or multiple drugs or no drugs. And they compared what was going on in the beginning of that registry, 2002 to 2005, versus more recent data, 2010 to 2013. And what they saw is that as we got smarter, doctors and women moved away from using Depakote, valproate, because we knew it was a dangerous drug. And as a result, the risk of having a baby with birth defects in this large population significantly went down. So people that were only taking one seizure drug, their risk went from 6% down to 4%. And women that were taking multiple medications for epilepsy during pregnancy, their risk went from 8% down to 6%. Those numbers may not sound huge, about a 2% drop, but it represents a lot of healthy babies. So it is important to shift the medication. It does make a difference in the risk of how things may go. And we're moving in the right direction. So doctors are getting smarter out there. All right, it's not just about birth defects. I told you that there also could be an influence on the developing brain of that baby exposed to the medication during pregnancy that could influence IQ, intelligence, or could influence behavior, including the likelihood they might have a problem like autism. There are several very, very well designed studies looking at babies from the time of mom's pregnancy and following up now to 6, 8 years, 9 years or longer with very, very detailed assessments of how those kids are doing. This is data from the United States looking at outcomes at 3 years, but really they saw exactly the same thing at 6 years, babies or children 6 years of age. So these were babies whose moms were taking either Tegretol, lamotrigine, phenytoin, which is Dilantin, or valproate during pregnancy. And let me say the highest risk for all these things is in the first trimester, because that's when all the organs and the brain are really developing. So in those first several weeks of pregnancy, what was mom taking? And if you look at that dotted line, so we have child's IQ at age 3 years after being exposed to these medicines in pregnancy. And then mom's IQ is actually the dashed line. And there's an interesting phenomenon that children's IQ is usually almost perfectly matched to mom's IQ. So we would expect everybody to kind of fall right along the dotted line. And if you see the only one that's following significantly lower than expected is the one I circled, that's valproate, Depakote. So once again, if you cannot take Depakote during pregnancy, that would be a good thing. Sometimes women have to take it. For some women, it's really the only drug that controls their seizures. And in that case, we want to be careful about the dose and we want to do everything we can to minimize the risk. But you can see that these other medicines didn't have an influence on child's IQ. So they seem to be safe in this regards. So where does this leave us with Depakote, with valproic acid? There's our recommendations, international recommendations. The ILAE is the International League Against Epilepsy. So based on everything we know about this drug, there are worldwide recommendations about the use of valproate for women with epilepsy. And the basic message is if you can use something else and you're of what we call childbearing potential, so whether you're a 12-year-old, a 22-year-old, a 42-year-old, if you're fertile and you could get pregnant, we really would prefer that you not take valproate, that we use something else. Valproate sometimes is the only drug that works for people with what we call generalized epilepsy. For focal or partial onset seizures, we got a lot of other choices. So we should really try a lot of those other choices before we use valproate for focal or partial epilepsy. There are women, like I said, where valproate may be the only thing that controls their seizures. And in that case, it's about weighing the risks and benefits, just like everything we do in life. You, however, should be having those conversations with your doctors. You should be educated about what the latest data is. And we like I said, that should be an active conversation, because just like what I know now is more than I knew 5 years ago and 10 years ago. Hopefully we'll know a lot more about how to manage this risk 5 years from now. I would also say there's a big difference between the person who says, I don't intend to get pregnant right now. I'm taking precautions against getting pregnant, and I really want excellent seizure control, versus the woman who says, I'm ready to get pregnant. I want to get pregnant. And so we should manage those risks differently. Okay. What about folic acid? So hopefully all the women here, whether you have epilepsy or not, we're aware that if you might get pregnant or you want to get pregnant, you should be taking folic acid. Why is that? Um, there's very strong evidence in the general population that we are usually deficient in folic acid, and that supplementing it, whether through a prenatal vitamin or just pure folic acid, which you can buy at the drugstore, reduces the risks of a very specific type of birth defect called a neural tube defect, which is where the spinal cord doesn't close correctly, or the brain may not close or form correctly. So a very serious type of birth defect. And taking folic acid can be extremely potent in preventing that. When you look at the data though, only 1 in 3 women with epilepsy is actually taking folic acid at the time of conception. So something that's so easy, so safe, low risk, that we should all do. Unfortunately, there is not evidence from the pregnancy registries to say that taking folic acid will block the bad things that a seizure medicine might do to the baby as far as birth defects. But there is evidence to suggest that it can improve IQ, particularly in those babies exposed to valproate. So again, there is evidence that folic acid has protective and good effects for your baby. You don't have to go crazy with it. Usually 0.4 milligrams for most women is a reasonable dose. So something very easy and safe that you can do, whether you want to get pregnant right now or not. A good idea for most women who are fertile. One of the most important things we can do is plan pregnancy for women with epilepsy. So why is that? Like I said, the time of greatest risk from your seizure medicine to the developing baby is in the first trimester, and particularly in the first 6 to 8 weeks of pregnancy. Meaning by the time you realize I missed my period, maybe I should get a pregnancy test, the baby has already had several weeks of exposure that may have an impact. So if we're going to adjust your medicine, whether it's what you're taking or the dose, or we're going to do anything else, we're going to get you on folic acid, you need to do that before you get pregnant to really have the greatest impact. Don't forget about the other things you can do to have a safe pregnancy, like quit smoking, avoid alcohol, all of those good things. Many women are concerned about what will happen to their seizure control while they're pregnant. You know, they have a fear. Again, this myth might be out there that just because you're pregnant, your seizures are going to get out of control. Not true. So again, I want to take that fear away from you. Overwhelmingly, most women will be seizure-free during their pregnancy. And I'm going to show you the data that says if you're not seizure-free before pregnancy, unless something changes, you're probably not going to stop having seizures. But if you are seizure-free on your medication prior to pregnancy, you are very, very likely to stay seizure-free during pregnancy. Status epilepticus is a type of seizure where seizure doesn't stop. It's a seizure emergency. Again, that would be kind of our worst case scenario. What if I had a seizure emergency during pregnancy? It doesn't happen any more often during pregnancy than any other time of life, and that's less than 2% of women in pregnancy registries that had that bad thing happen to them. Seizures during labor and delivery, again, you can see the scary things that go through people's minds. You know, they're already nervous about labor and delivery, and then they worry, what if I have a seizure? Doesn't happen very often, less than 5% of the time, and almost always in women who were having seizures during their pregnancy already, so not necessarily a surprise. So baseline seizure control prior to pregnancy will be a very, very strong predictor of what will happen during pregnancy. And from this graph, which is from the European Pregnancy Registry, so again, 21,000 plus pregnancy observations, you can see that women that were seizure-free for 9 to 12 months before they got pregnant, almost all of them stayed seizure-free during that 9 months of pregnancy. Okay, so the longer you've been seizure-free, the better seizure control, you're in good shape. So be reassured, if you're doing well, you're going to keep doing well. What are things we think about when somebody is pregnant? How do we optimally manage their epilepsy? Of course, we want you to continue taking your seizure medicines. It's safe for you. It's good. You know, your seizure control is important for your working and driving and your safety. We do recommend following your seizure drug level in your blood periodically. Frequency depends a little bit on your situation and the drug you're on, but your body goes through a lot of changes and sometimes we need to change the dose to compensate for that. Very important to try to maintain sleep. Why? Because sleep is a common cause of breakthrough seizures. We want to start thinking before the baby is born about breastfeeding, and I'll talk to you about the risks of that or the lack of risks with that. And I would encourage any of you, if you do become pregnant, just like I'm able to help you from all the thousands of women who participated in this registries, if you would consider participating in a pregnancy registry, you'll help all the women's pregnancies that come after you. After the baby's born, postpartum, if your medicine had to be adjusted upwards while you were pregnant to you know, compensate for all the things that were going on with your body, we want to remember to get that back down so you're not on too high of a dose. Usually follow those levels for at least a few weeks or months afterwards. Get back on birth control if you need to, and then sleep. You know, sleep with a newborn is always a challenge, but it does help to have a plan about, you know, who can help you with nighttime feedings, who can give you some relief if you're really getting exhausted to maintain good seizure control. All right, breastfeeding. Again, one of those urban myths that women are told you can't breastfeed, it's not safe. The medicine is in your breast milk and you're going to give it to your baby and somehow cause problems. Women with epilepsy, because of this myth, are less likely to breastfeed. Why do we care about that? Because breastfeeding is good for moms and breastfeeding is good for babies. It's good for mom's health. It helps reduce postpartum depression. It helps with babies' short and long-term health. And breastfed babies have higher IQ. So I get it. Not everybody is able to breastfeed. Not anybody, you know, has the choice to breastfeed, but don't let anybody take the choice of breastfeeding away from you because of your epilepsy or because of your seizure medication. Yes, there may be some seizure medication in your breast milk, but when they have done studies, and people have done these studies where you measure what that means as far as medicine in the baby's bloodstream, that level is usually minimal to undetectable, meaning it's not having an impact, and it's much lower than the baby was already exposed to during pregnancy. And when you think about, well, who cares? We use these medicines in babies to treat their seizures. So what's the downside? What's the risk of harm if the baby is exposed to some small amount of seizure medicine? Well, many people worry about the long-term effects. And again, when we look at long-term IQ and behavioral outcomes, the breastfed babies do better in the long run and the short run. And that includes babies that were exposed to valproate, Depakote, what we think of as our riskiest drug. So again, if you want to breastfeed, if you're able to breastfeed, go for it. You should. What if I don't want to get pregnant? So let's switch gears. Not everybody wants to have a pregnancy. Sometimes we don't want to get pregnant. So what's the importance of contraception? Again, I already told you that we really would prefer that pregnancies are planned so that we can manage medication to the optimal point. Unfortunately, about half of pregnancies in the United States are unplanned. And in surveys of women with epilepsy, as many as 65% said that their pregnancy was unplanned. That doesn't mean unwanted, doesn't mean they weren't happy, but again, they didn't have an opportunity to plan. And in large part, that's because women with epilepsy were not advised that there could be an interaction between their seizure medicine and the contraceptive that they were using. So in a recent study of women with epilepsy who all had the potential to become pregnant, but said, I do not want to become pregnant right now, 37% were actually not using a highly effective form of contraception. Some of them thought they were, but what they were using in combination with their seizure medicine was no good. And let me acknowledge that there's also a barrier, like many things in the United States, related to health insurance. So 80% of women without health insurance did not have access to effective contraception, and that's a big, big healthcare issue for us. We do have a number of seizure medications that if you take it with a standard hormonal contraceptive, it will stop the hormonal contraceptive from working the way it's supposed to. So you can read the list of medications. I don't need to read them for you. You don't have to memorize this. I would say if there's ever a question, check with your pharmacist, to say, I'm taking this seizure medicine. I want to go on an oral birth control pill or whatever it is. Is there an issue where there's an interaction between these two things? because your gynecologist may not always know. Your neurologist absolutely should know, but somehow this seems to slip through the cracks in communication, and the stakes obviously couldn't be higher. So why is it that this happens? All of those seizure medications, not in a dangerous way, but just in a natural way, they rev up some of the enzymes in your liver that break medicines down, and that includes breaking down the hormones in these contraceptives. So it's not just the birth control pill that's impacted in this way, it's also emergency contraceptive, the morning after pill, the vaginal ring, the transdermal patch, Implanon, that's the little tubes that go in your upper arm. Possibly Depo-Provera, although that one's a little controversial. Depo-Provera may be okay with most of these medicines. So if you are on a drug on that list and you say, I got to take it, this medicine works for my seizures, I got to stay on this, but I don't want to get pregnant, what can I do that is still highly effective for contraception? You can use an IUD, which is tremendously effective against pregnancy. And that's true whether it's pure copper or whether it's copper with a little bit of hormone in it. A tubal ligation, extremely effective, obviously not an acceptable option if you want to get pregnant again down the road. And by the same token, remember, it's not all the women. Guys can do their part too, and a vasectomy is extremely effective in preventing unplanned pregnancy. All right, so I'm going to wrap up here and have time for questions. I just want to remind everybody it's a journey. You know, our goals with our patients are always no seizures, no side effects, no lifestyle limitations, and that absolutely means no limitations on your ability to have the family that you want, the pregnancy that you want, the sexual and reproductive life that you want. Like I said, for some of you it's easy, for some of you that's hard, but we're happy to keep fighting with you. And then just a final reminder, stay safe out there. So mask up, everybody. And with that, I'm happy to take questions. I don't see anything in the chat box right now, but I can hang out and see if anybody types anything.
Great presentation, Dr. Noe.
Thanks, you're welcome. Nothing? Either
If
your
anyone has any questions later, you can always email us at az@efa.org, and we'll pass it on to Dr. Noe, and she can answer later as well.
yeah, happy to do so. Okay, so we did get one 16-year-old taking Depakote, valproic acid, 1,000 milligrams daily. What would be the recommendation? So again, I got to speak in generalities because obviously there's a lot I don't know about that person's seizure disorder. So couple caveats. Number one, I would always say if we can use another seizure medicine safely, then let's go ahead and do it. Because like I said, even that 16-year-old who may say, I don't want to have kids in the next decade, but remember what I said, it's really unplanned pregnancy we have to worry about, or, you know, or maybe pregnancy is closer in her future. So it depends on the type of epilepsy she has. Obviously, I don't know the story. Has she tried 20 other drugs and Depakote is the first thing that worked? You know, there's a lot that goes into that conversation about, is there another drug that would be equally acceptable? If the answer is yes, I would stop the valproate. I would stop the Depakote. If the answer is nope, we've exhausted the choices and this Depakote is doing fantastic, it's finally controlling her seizures, she's living the life she wants, she's not planning on getting pregnant, what I would say is leave it alone. Make sure that she is absolutely educated about what the risks are of pregnancy, that she is empowered to make good decisions. And if she is sexually active or she's going to be sexually active, make sure she's on a highly effective form of contraception. So it sounds like the question is saying generalized epilepsy, but it's the only drug she's taken. So in that case, like I said, you can weigh the risks and benefits, but I would sure think about trying something else. Good questions. I think that's the only question I see.
Okay. Thank you again, Dr. Noe.
You're welcome.
So I'm hoping that everyone will join us tomorrow, since we will have Dr. Chung and Dr. Herman speaking. Thank you again for coming, and we are recording this, so we will have this on our website later. Thank you. Good
Thanks
night.
everyone for attending. Thank you, Suzanne, for having me.
Oh, you're welcome. Bye-bye.